Hello, my name is Susan Mayer and I'm a medical journalist and broadcaster. Welcome to this webinar on improving perioperative patient safety and outcomes. We're delighted to be joined by more than 100 people from across Europe. Patient safety during and after surgery is a major concern for all of us because each of us or a member of our family will almost inevitably have surgery at some point in our lives. When we think about the potential risks of having surgery, most of us focus on those associated with the procedure itself, but there are other safety issues of which we may be less aware, but which are only too real. One of these is the changes in our blood pressure that can occur during or after high-risk surgery, which can result in reduced blood pressure that can lead to serious and sometimes fatal complications. And that's what today's webinar is all about. We're going to hear from policymakers, clinicians, and patients' organisations on why and how this is important. But it's a previously neglected aspect of patient safety that needs to be highlighted and addressed. So how can you take part in today's webinar? Well, we want to hear from you with questions. So at any point during the session, if a question occurs to you, click on the Q&A button at the bottom of the screen, and you can then type your question to the host, i.e. me, and panelists. And we can either reply directly to you in the Q&A session at the end of the webinar, or we'll answer your question afterwards by email. So I would encourage you, please send in those questions on this very important issue. First, I would like to hand over to Kieran Cuff, member of the European Parliament for Dublin, who's going to explain a little of why this is an issue of concern to European parliamentarians. Thank you.
Well, thank you. And thank you so much for the opportunity to join you today from Brussels here in Belgium. And I want to really thank you as participants, as well as the members of the Improve think tank for the preparation of the manifesto for improving patient safety through stable blood circulation during surgery, commonly known as hemodynamic stability. And when we talk about stable blood circulation, we often think about high blood pressure. For example, in my country, Ireland, this represents a persistent problem for 2 out of 5 people. However, when undergoing high-risk surgery, the main concern is low blood pressure. And even 1 minute of low blood pressure can have a significant negative impact on a patient's recovery. So if as little as 1 minute can have this impact, it's important that it is monitored and rectified before it causes harm to the patient. And the Improved think tank and the manifesto are heading precisely towards these goals. And crucially, this is not a manifesto that asks for action without specifics. And I know that today we will hear about the targeted recommendations and the practical actions we can pursue to address the challenges associated with low blood pressure during surgery. And our experts will be able to tell us much more about the risks that patients run while going under high-risk surgeries. But from the point of view of us as policymakers, there is a lot to be done. And the calls set out in the manifesto, they're very clear and they're concrete. And when it comes to hemodynamic instability during surgery, the risks are still not sufficiently known, and the drive to monitor these side effects in Europe has been low. As such, at a time of major changes and modernization in healthcare, patient safety must remain at the center of the discussion, and we can do a lot more as policymakers to ensure that changes move in the right direction to address the threats of patients being at risk due to low blood pressure during surgery. And there's an increasing need to find smart digital solutions to better protect patients undergoing high-risk surgeries. The digital agenda is present in all of our work here in the European Parliament. But we are well aware of the aging of the European population and the pressure that hospitals and healthcare professionals have been under, particularly during the COVID-19 pandemic. And surely the first step must be to ensure that all patients undergoing high-risk surgery are made aware of the importance of managing blood circulation and how they will be monitored and managed. But that isn't enough. There's a lot more that can be done at a legislative level. For example, to support the proper implementation of national and European guidelines on optimal blood circulation in surgery. And moreover, we can ensure that all European countries provide funding so that healthcare systems can take advantage of the benefits for patients that come from modern digital technologies. You know, looking back over the last 18 months, it can be said that the COVID-19 pandemic caught us unaware as policymakers. One of the reasons for that is that health traditionally has not been a European competency. It has been devolved to both the member state, the national level, and indeed to the regional level. But we are certainly rethinking this. We are increasing the funding to bodies like the European Centre for Disease Control. And I think in the years ahead, we will see not only greater funding, but greater links and connections and attention coming from the European Union and the other European institutions to make sure that we improve the health of the 450 million citizens who live in the European Union. So I think your event today could not come at a better time to focus on these issues. And I certainly appreciate your participation. I look forward to listening to the insights that will emerge from today's discussion. And I'm sorry, my colleague Sean Kelly is unable to be with you today because of another commitment, but he sends his best wishes to you all for your deliberations today. So many thanks and good luck in your work.
Thank you so much for that very inspiring introduction. And we're going to hear from Sean Kelly at the end of the webinar, even though he can't be with us. So just very briefly, how are we going to explore this very important but often overlooked aspect of patient safety? First of all, we're going to hear about the Improving Perioperative Patient Safety and Outcomes project, the think tank from Professor Olivier Huet. We're then going to hear why poor blood circulation during surgery is more than just a monitoring challenge. It's a real safety threat, and we're going to hear about that from Professor Monty Mython. Professor Michael Sander is then going to tell us why every minute matters of maintaining circulation during surgery. And then we're going to hear from the people at the very heart of this, patients, putting patient safety at the heart of what patients know by improving communication, from Luciana Valente, and then finally hearing what the European report on this recommends and calls to action, rounding up from Monty Mython. As I mentioned earlier, we then have a time for some questions, so do send in your questions on the Q&A chat link, and then we'll hear from MEP Sean Kelly at the end to bring the meeting to a close. So without more ado, I would like to hand over to Professor Olivier Huet. Olivier is Professor of Anesthesia and Intensive Care Medicine at CHU La Cavale Blanche Université de Bretagne West, France. So Olivier, tell us more about perioperative patient safety and outcomes.
Thank you very much, Sue. And I would like first to thank the MEPs for hosting this webinar and the interest that they have on this subject matter. The Improved Think Tank is a pan-European group. Next slide, please. And the particularity of this group is that we have some anesthesiologists and intensivists joining with surgeons and patients association. And we all discuss together about specific topics, and we are interested in optimizing patient safety and outcome. What we thought that there was a burning issue considering perioperative care, because 2.4 million patients undergo high-risk surgery every year, and the mortality and serious complication rates within the 30 days after surgery remain extremely high. Just a number, 1 in every 100 patients will die from complication within 30 days, and this number goes up to 4% after 1 year. Of course, there's a room for improvement in a lot of the care we are giving to the patient, but we wanted to focus on hemodynamic instability. Hemodynamic instability is manifested in a drop of cardiac output and in blood pressure, and is known as intraoperative hypotension or perioperative hypotension. This leads to poor blood circulation, and poor blood circulation leads to poor organ perfusion. It occurs very often. Over more than 99% of the patients undergoing high-risk surgery will have an episode of intraoperative hypotension or perioperative hypotension. And this has severe post-operative complication and puts patients into high risk. And at the end, it has a significant economic burden. What we want to achieve, firstly, and obviously, we want to improve perioperative outcome of our patients. And what we would like is to decrease the number of complications the patient may suffer, and this will shorten hospital length of stay, as we hope. We will also avoid rehospitalization, and this will hopefully optimize the cost of our healthcare system. I will now let Professor Monty Mython from the United Kingdom to talk to you about poor blood circulation.
Olivier, thank you. I just want to start by saying thank you to Kieran Cuff and to Sean Kelly for co-hosting this event. It's, as you said, it's a shame that Sean can't be here, and hosting us from Brussels. As luck would have it, I myself am actually on the west coast of Ireland at the moment, on the Dingle Peninsula, where I've just finished hosting a global virtual event of over 1,000 clinicians, where we've been discussing current controversies in anaesthesia, intensive care medicine, and critical care, and particularly in the wake of the COVID-19 initial surges that we've been dealing with. And this issue that we're about to go into greater detail was right at the top of the agenda, as we're facing the enormous backlog of elective surgery. So poor blood circulation, more than a monitoring challenge and a real threat. So why does blood circulation matter during high-risk surgery? Well, all of our organs need an adequate blood supply. They need that for the delivery of oxygen, the removal of toxic waste products at all times. But it's even more critical during major surgery. And during major surgery, there are many different pathophysiological mechanisms that can lead to a poor blood circulation. And that's the combination of anesthesia combined with the traumatic insult, although it's ultimately beneficial, of surgery. And this includes widening of the arteries caused by anesthetic drugs or systemic inflammation in response to the trauma of surgery, significant bleeding, which is also referred to as hypovolemia, reduced heart rate or bradycardia, and the impact of taking over the work of the lungs by us using mechanical ventilation. And when this happens without action, it can cause very significant harm. Poor blood circulation, or intraoperative hypotension, as we'll refer to it as well, has the potential to cause tissue damage in any organ, and indeed any vital organ. But the heart and kidneys are most commonly affected. A significant amount of research is pointing to a strong association between intraoperative hypotension and increased risk of myocardial injury and acute kidney injury in non-cardiac surgical patients. Myocardial or heart injury in the first 30 days following surgery is the leading cause of post-operative deaths. Each year, more than 10 million adults worldwide have a major complication in the first 30 days after non-cardiac surgery. And data shows that 1 in every 8 patients will experience post-surgical myocardial injury or acute kidney injury following non-cardiac surgery.
Thank you, Monty. Those numbers are really make us all sit up and think. So handing over to Professor Michael Sander. Michael, if you would like to tell us why every minute matters. Michael is Professor of Anesthesiology, Operative Intensive Care Medicine and Pain Therapy at the University Clinic in Gießen, Germany.
Well, thank you very much for the honor to present here. I'm really happy that you're all here and we have the possibility to talk about this very important issue. And thank you, Monty, for basically setting the stage why every minute matters, that we have a close look on the circulation of our patients. It's hard to believe, but it's a lot of work from a lot of different people, especially from Dan Sessler from Cleveland Clinic, that we had the possibility to learn that what we do in the OR really matters, as we learned that every single minute of poor blood circulation during surgical procedure can be really dangerous to our patients and increase the risk of serious harms. We learned that from a lot of studies done by a lot of people, that the work of us as anesthetists in the OR is really important. And in the next slide, we see obviously there are barriers to optimal blood pressure measurement. First, and really importantly, we need to get more data. It is that we still need to find a causal link between poor blood pressure and organ injury and potentially death. Also, identifications of patients at high risk for complications, that has to be improved prior to the surgical procedure. And we also have to learn how catastrophes during surgical procedures can influence that risk. Obviously, we have also a lack of specific pathways for those high-risk patients that need to be implemented in our clinics. The next thing is advanced monitoring will cost some money. We believe that this money is well spent if we are able to prevent complications, but that topic has to be solved as well. Then, a little bit disappointing, we have still a very low implementation of blood circulation guidelines. There are some papers who basically tell us how to treat our patients in the OR and in the ICU, but at least the implementation of those guidelines is not extremely high at the moment. And finally, there is generally a low awareness among anesthetists of the danger of low blood pressure and low circulation during high-risk surgery. We have certainly to work on that, and that is obviously not so easy, because after surgery, the patient might look quite well, but the complications will develop after days, sometimes after weeks. So the causal link is hard to recognize from the individual anesthetist. In the next slide, we see how we can maybe design a sort of ideal patient pathway. Obviously, first, when we select patients for example, advanced monitoring, we have the point where the patient meets clinicians, including the surgeon, anesthetist, sometimes other disciplines, where we discuss the procedure, we discuss about the risk, we inform what actions we will take as a team to mitigate these risks. We will have a pre-operative assessment to identify risk factors and cardiopulmonary fitness of the patients. We have to decide together as a perioperative team with the patients whether the potential risk of the operation outweighs the potential benefits, and ultimately take the decision to proceed with the surgical procedure. And then during the procedure, we have to identify patients who really can have the benefit of advanced monitoring tools. various non-invasive and invasive digital monitoring devices are there that can give us further information about our patients, how we can guide the circulation, fluid management, blood flow, and blood pressure. And in the end, we should continue this monitoring in the intermediate care, in the surgical care ward, and also in the peripheral ward in the post-operative period. And there's still some work to be done, especially for the normal ward, to detect poor circulation there. And in recent years, we learned that there is some monitoring that can use advanced technology to detect and predict blood pressure drops ahead of time, because at the moment, treatment of poor circulation and severe drops in blood pressure is mostly reactive. We just treat them when they occur, and in the future, it would be helpful if we could treat them ahead of time, basically preventing those events. And in the end, managing these complications will include that we identify patients who will have a benefit using those tools, where we can use sort of goal-directed therapy strategies, because that has been shown in high-risk patients to improve outcomes after surgery, preventing complication, preventing harm to our patients, and in the end, also saving money. And for the normal ward, a future outlook is that we might be able to use advanced monitoring also in the normal ward, have electronic warning system and emergency teams picking up patients at a very early stage of complications to treat the complications before they can cause irreversible harm like kidney injury, kidney failure, and even death.
Thank you. That sounds a very good prospect. And now we're going to hear about putting patient safety at the centre of this, starting with putting patients in the know. We're going to hear from Luciana Valente, who's International Relations Manager with Senior International Health Association based in Italy, but taking the global perspective. So Luciana, over to you.
Thank you for giving me the floor. Good morning, everyone. I can say that is an important moment to further develop the topic we are talking about today, and I am sure it will add value to discussion around it. I would like to raise a point on optimal patient safety. It starts with making patients aware, informing them, and involving them to make them an active part of the care and treatment process or their procedure. We now know that poor blood circulation is a hidden concern for patients. Hemodynamic instability and its impact on patients is a pressing concern, especially considering the aging population of Europe. By 2050, it's predicted that 1 in 4 people could be over 65. This brings a myriad of potential health challenges for surgeons and anesthetists, particularly with hemodynamic instability, reported as high as 83% in more senior patients. With the rates so elevated, the improved think tank believe hemodynamic instability to be a likely cause of a significant proportion of avoidable postoperative mortality and morbidity in Europe, as well as patients often assuming safety during their procedure. They are also unaware of the risks of not receiving innovative digital monitoring technology, meaning they may not ask for the best perioperative management. There is an urgent need to protect patients from hemodynamic instability now and improve patient safety in the future. To protect patients and improve their safety, they should be informed about the monitoring they will receive as a part of their pre-operative briefing. Our work as a senior international health association is to involve senior citizens and patients in the promotion of good health information and make them more aware of the risk of their health. Even if traditionally the surgeon was considered the driver of perioperative patient outcomes, this perception is now changing, and patients are a key player in their own surgery and outcomes. In the next slide, when we talk about improving patient safety, we are talking about better patient outcomes and quality of life, faster recovery, and less time in the hospital intensive care unit. Not forgetting the lower risk of a rehospitalization. This means better quality of life for people, but also lower costs for healthcare systems. If we look at the demographic change expected in the population with increasing aging, this will mean longer-lived people, and by improving their quality of care, we can also have more sustainable healthcare system in the future, benefit all age groups of population. But to achieve this, we need to overcome the assumption that patients make about their safety and involve them better in the risk dialogue so that they are more engaged in their own outcomes and safety. To do this, the collaboration of the hemodynamic team is essential to improve the type of communication to be used with patients, especially for senior people and their families. Clinicians to involve patients in a dialogue about the risk of poor blood circulation, so they are invested in the action taken to ensure the best outcomes and safety before, during, and also after the surgery. Indeed, if I'm having a procedure, I want an optimal outcomes. If there are barriers to that optimal outcome, I want to be a part of that conversation and to be a part of removing those barriers, if possible. Risk communication and active dialogue is an essential element to work on. We work to lead the cultural change, and I am delighted we are all working to further develop this specific topic. Thanks.
Thank you so much, Luciana, for really making us clear on the central role of the patient in this and what needs to happen. So, Professor Maithan, I'll call on you now to tell us what calls of action is the Improved Think Tank recommending to really make a difference in this very often overlooked area of patient safety.
Thank you very much. So as you just heard, I'm going to highlight our European report and briefly articulate our calls to action. So positive outcomes of high-risk surgery are the desire of all patients, anaesthetists, surgeons, and the whole perioperative care team. However, despite significant medical advances, European morbidity and mortality in the 30 days after surgery are too high. So this group met virtually over 2020 and 2021 to address and propose solutions. Next slide, please. So we have 4 calls to action: train, invest, support, and involve. We think this allows every stakeholder to step up to a particular challenge. So when we say train, we want to ensure adherence and implementation to new European guidelines on blood circulation during surgery by improving training for clinicians. Invest. We want to secure appropriate funding for hospitals to invest in innovative digital monitoring technologies to help us maintain stable blood circulation during surgery. Support. We want to recognize in health data policies the value of data generated by innovative digital monitoring technologies to better support health policies for improved patient safety. And finally, involve. We want to involve patients in a dialogue about the risks of poor blood circulation So they're invested in the actions taken to ensure the best outcomes and safety before, during, and after surgery. Thank you.
Thank you so much. So now we have plenty of time for questions. So just calling up, just starting to think about questions. An opening one for you, Professor Huet. Why are you launching this think tank report and call to action now? Why is it important? Question for Professor Huet.
Well, I think it's critical. It's a critical time for us, and we all agreed in the think tank that there was a miss in translation into clinical practice to be proactive when in the occurrence of hemodynamic management, when we wanted to do hemodynamic management, and we don't really know why, because we are. Monty Myton, Michael Sanders, and I often have plenary sessions in Congress. Everybody knows the problem, but it doesn't translate into clinical practice. And I think it definitely is a time to try to step out of the medical field and ask other people to help us. And it's why we wanted to have patient organizations with us, so we can have a broader public in order to try to address this situation. As we said, there's more and more people undergoing high-risk surgery, so definitely there's something to do.
Thank you. And Luciana, can I bring you in on that question too? Why did you want to be involved in this initiative? Why is it important that action is taken?
But I think that there are several barriers to patients being informed and monitored and involved in transparent discussion. For example, lack of awareness among all stakeholders of complications during the surgery, such as hemodynamic instability, and resulting in the absence of specialized care pathways and the law of adherence to standard. And also lack of access to necessary advanced hemodynamic monitoring technology or hemodynamic champions, of course. I think also the cultural resistance, where patients are unaware of the care role the anesthetists play in patients' outcomes, or taking a passive role in their treatment.
Thank you so much. Professor Myton, a question for you. Could you just tell us more broadly about the think tank initiative? What patient organisations and professional societies are supporting this? Several of you have mentioned the need for everyone working together on this. It's more than just the surgeon, it's everybody, including the patient. So could you just briefly tell us who is taking part in supporting this?
So I mean, collectively, I think we represent quite a broad church. That was the deliberate move in bringing the group together. And when you do that, you often get asked, well, why didn't you work with one of the existing societies or colleges, for example, of which between us, we have sat on or do sit on very many of those types of bodies. And I think the reason there is that when one does take that route, there tends to be a little bit of tribalism that creeps in, you know, as opposed to it being a big message, a big tent, and you know, this is about all of us, and particularly the patient representative involvement and the payer involvement. So I think that's why we took that route. Now we've been discussing it with as many people as possible, you know, all the usual routes you'd expect, and you know, all very positive messages so far. Everyone's very supportive of the message. I mean, you know, why wouldn't you want to improve patient outcomes? So no pushback from anyone, and also a possibility that these endeavors would be transferred into an appropriate group in the future, more likely to be one of the sort of patient safety type of groups rather than a subspecialist group, you know, team anesthesia, for example, or team surgery.
Thank you. Just briefly, what makes this different to other initiatives in this space?
Shall I take that one? Is that what that means?
Yes, just briefly.
So I think it's it's a European initiative. I think that's a key component of it. The patient representation is very strong. It's interdisciplinary, and I think those are some of the distinguishing factors. And it's not single disease or organ specific, which you may say, well, you know, what do you mean? But you see, many of the endeavors are, for example, kidney specific or heart specific. This is much more holistic.
Thank you. That's great. Luciana, a question for you. How you mentioned the importance of improved dialogue in practice. How do you envisage that actually happening? Patients being more informed about this whole area?
But I think in practice, patients often assume safety during surgery. However, they should be informed that no surgery is without risk, of course, but reassured that actions such as the use of advanced hemodynamic monitoring technology will be employed to mitigate these risks. Discussing with patients for quality of life after surgery or positive outcomes may be more appropriate than patient safety. Any patient facing material should be short and written in a lay format to aid understanding this specific key message, I think.
Thank you so much. And this relates to a question that we've had in from the audience. Professor Sander, can you tell us briefly who is at particularly high risk for intraoperative hypotension? Are there any particular groups? Is it easy to identify who's at risk? Who should be aware of this?
Well, the risk for hypertension during surgery is quite universal. So basically, a lot of patients might experience that, but the fact that most of them will survive surgery without complications shows that very healthy patients, the risk is quite low. But patients with comorbidities, with very big surgical procedures lasting longer than, let's say, 2 hours, big abdominal surgery, there is a substantial risk that, especially if patients, for example, have some sort of kidney problems before surgery, some other problems will develop severe complications that last for a prolonged time, like delirium, like kidney injury, like an increased rate of infections, stroke, and even death.
Thank you. Thank you. That's very clear. And there's an interesting question that's come in on the chat. How can frontline clinicians be supported and involved in this whole initiative? Olivier, if you'd like to speak to that first. So how can frontline clinicians be involved in this and take action?
Do you mean anesthesiologists or physicians?
The question is frontline clinicians. So I think we need to think in the broader sense there, particularly as you said, this should really involve everybody.
So, well, I think information is very important, and as it has been said, informing patients is a key matter. So I think, for example, general practitioners should be aware of the risk the patient are taking when they undergo high-risk surgery, and therefore I think we should have a better communication on this for the other practitioner than the anesthesiologist. And after, regarding the anesthesiologist, they are a human like all of us, and you believe in what you see. And the problem is that the complication occurs within several days, several weeks, or several months, and we don't always see the patient at that time. So informing more and training better the anesthesiologists and intensivists on the risk and on what happens after is a key action to have, as Monty said.
Thank you. And Monty, just coming back to you again, can you just briefly summarize again the key recommendations that you as a group think will make a difference, and what's needed to implement these? How are they actually going to happen in practice?
So that the 4 calls to action were train, invest, support, and involve. Now, the train one is seeking, adherence to our existing and evolving European guidelines. So that's a job that we've just asked a question about how to get involved. That's something we can go back to our institutions wherever we work next week and see what we're doing about that. Are we reminding people that almost every guideline everywhere says we have a responsibility to maintain a reasonable blood pressure? The investment side of it, well, that's partly what we're doing here today. We're saying to the policymakers, can you please make this a priority issue? Because we think it's a high value investment. If we look at the quantum of harm associated with this, and we think what to do to avoid the problems, what a great ask. Then there's the support, and the key support side of it is data, a recurring theme around the world, irrespective of how much resource there is in the healthcare system, is we are working in a relative data void. If we don't know the rates of acute kidney injury after surgeries when we're caring for patients, or acute myocardial infarctions, we don't prioritize the investment and the training. And then the final bit, which we've been hearing a lot about, is the involve. The patient is the center of everything we do. It's the patient's heart, it's the patient's kidney, it's the patient's brain we're trying to protect. Their awareness of the risks shouldn't be to scare anybody. It should be to say, can we work together to do our very best to try and keep my brain, keep my kidneys, keep my heart? Because I'm highly motivated that you do the support, invest, and train elements of it to look after me.
Thank you so much. That's really helpful. And then just thinking about, as this is being hosted from Brussels, what can policymakers do to help with those actions you've just recommended? And Olivier, maybe what are you calling on policymakers to do here? What would make a difference?
Well, this policymakers can do a lot of things to help us, of course. But one key action is once a physician or an anesthesiologist is trained, he needs to be able to access to the technology, and the technology has a cost. And if policymakers make the budget of the hospital or the healthcare system, so definitely we need a change in the policy so the healthcare system have the money to buy or have rules or guidance to know that this is a priority. So I think policymakers, with the help of the patients association, should be able to tell the healthcare system that there is a need to improvement, and the policymakers will try to help by changing the budget of the healthcare system or giving some budget for this, and also to promote the knowledge in the teaching hospital and also try to implement European guidelines and to renew them as much as possible.
Thank you. With the very pressing calls on healthcare resources, perhaps more than, just more than ever we've seen in any of our lifetimes, it feels like at the moment, how can managing intraoperative hypotension be included in that? Professor Mython, just put that to you.
Well, I think I referred to the fact that every guideline that I'm aware of everywhere says that we have a duty to maintain a reasonable blood pressure. It's kind of, self-evident that that would be one of our objectives. And now we have access to large electronic health records and data to inform us. We have been shocked as how common low blood pressure is. In other words, an inadequate circulation that's associated with harm. And the harms that they cause are not only very miserable for the patient, the financial implications are massive. You know, if acute kidney injury turns into chronic kidney disease that requires dialysis, the financial quantum is enormous. So the value proposition, that sort of the cost versus the improvement in outcomes, is so high that we think it should be a priority. And that's mixed in with the realization now that death after surgery, irrespective of the part of the world you are in, so if you're lucky enough to get surgery, which is unusual in some countries, is now the third commonest cause of death in the world. It's more than HIV, tuberculosis, and malaria combined. So if that's not a public health priority, I don't know what is.
Thank you. Very clearly put. And then Professor Sander, just coming back to you again, what difference would improved monitoring and management of intraoperative hypertension really make to patients undergoing surgery who you're operating on, and to clinicians caring for them? What differences would we see if that improved?
Well, we learned a lot from studies looking at goal-directed hemodynamic management and fluid therapy, and that really decreased in some studies up to 20% the risk of patients suffering bad outcome after surgery. And we do hope to show that with the running studies in the future, also with the monitoring equipment to prevent hypotension. And as basically Monchi said it, it's a catastrophe that some patients undergo surgery with the hope to have a better life after the surgical procedure and end up with kidney failure. And that is what we hope for some patients we might be able to achieve with advanced monitoring. And that's about it, preventing harm for our patients.
Thank you, that's very clear. Question, Luciana, a question for you that's come in from a member of our audience. There's a lot to discuss with a patient before they have surgery, particularly high-risk surgery, in terms of possible complications. Is adding this in just making it even more complicated and frightening for them? You mentioned the importance of involving the patient. So how important is it for patients to be fully aware of all risks in surgery, and how do doctors manage that well?
But I think that if patients are more aware of the risk regarding their surgery and asking the right question, clinicians will be more forthcoming to converse with them on the matter. Patient, in this case, in this to help ensure policy change for more money, and to help educate topic, but also to help fund also hospital. Therefore, we believe that highlighting the issue and raising awareness among the rest of the society encourage, I think, the change. And I hope to answer your question for patient.
Thank you. That's absolutely great. And then thinking about quality standards for hospitals, how should managing intraoperative hypertension be incorporated into quality standards, which are often used to drive up patient safety and care? So how does that happen in practice, and how does it happen across the whole of Europe? Olivier.
Well, at this stage in France, there's no policy for quality standards in hemodynamic monitoring, but I would say that the best way to answer this is to make sure that the practitioners believe that having a proper hemodynamic treatment during surgery will improve the outcome of the patient, and not necessarily having quality standard overview from the administration telling him that this is what he needs to do. Because what we can see is that if you implement this type of policy, well, you just need to have the monitor in the operating room, and it doesn't mean that you're using it. What we want is people to use these monitors in order to treat better the patient because they believe it's going to be better. And this will lead to a change that will last, and not something, just a policy that will go and disappear in 5 or 10 years. So what we want is to improve the knowledge of the practitioner, so they are aware that it's important to do it, and they know how to do it, and they have the means to do it.
Thank you. That's very clear. And then Monty, just a quick question for you, and then I'll go around and bring this together. What's next for the work of the Improved Think Tank? So what is going to happen with your report? And could you just briefly tell us how the report is funded, just so that that's clear for us? Thank you.
Thank you. So we've already been doing some awareness work. I mean, this is obviously the major launch, and I want to thank again for being hosted by the European Parliament. You know, as often happens with these things, stage one is communication. So we must do as much as possible by talking to as many people as possible to get people talking about this and to discuss. You know, maybe we haven't come up with exactly the right ideas, but if we get people debating and discussing that, that would be great. From the funding perspective, initially we received an unrestricted grant from Edwards Life Sciences. You always need some resource to get these things going. Unrestricted, that's a sort of a term we quite often use in medical research and in education. It doesn't mean as much money as we'd like. It means that a grant is made, and then once the grant is made, there are no strings attached to what happens next. But that always raises some sensitivities. So we have collectively a plan to get multiple other sponsors, and many of those have already agreed in principle, and then to transfer, let's call them the assets, this endeavor, into a hospital charity and then into a not-for-profit, unless in the interim we identify an appropriate partner, one of the patient safety movements or another society, etc., to take it forward. So an enormous thank you to Edwards Life Sciences for getting us going, but we will need to find additional resources to continue the work. So if anyone is up for supporting us, please do be in touch.
And you mentioned earlier that a wide range of organisations had inputted into the work so far.
Absolutely, absolutely.
So it's very broad. So thank you. So just bringing that together, we've heard today intraoperative hypertension is common, occurring in up to 99% of patients undergoing high-risk surgery with potentially complex complications. The group we've heard from today is calling for discussion, dialogue and action to really move this forward and get things changed. The potential benefits are greater patient safety, which is at the core of what everybody here is aiming to achieve. So thank you to that, for that from everybody. We're now going to hear from Sean Kelly, our MEP, who is going to just bring all of that together for us to summarise.
Hello to you all. It is with great pleasure that I take this opportunity to thank the Improved Think Tank for its dedication to improving patient safety through stable blood circulation during surgery. With all the technological and medical changes of recent years, there is a need for reassessment of current guidelines and the training to ensure their effective implementation. This seems the necessary and logical first step to take, and for me, this discussion touches on the use of health data, a topic I particularly care about. With new technologies in place for clinicians and patients, we do need to achieve a good balance between using patients' health data and properly leveraging the opportunities that these instruments can offer. We also need to appreciate that the EU and Member States are showing a great commitment towards investment in healthcare, and we as policy makers can ensure that actions and investments are exploiting the real potential that relies on such funds and on these radical changes around us. In other words, we can support clinicians and patients to secure funding opportunities to invest in technologies which improve patient safety during surgery. If we are putting patient safety first, we need to involve patients in the discussion. I am pleased that patient groups representatives are part of this initiative. They will be able to support physicians in ensuring patients are fully informed about how their surgical procedures will be monitored and managed. The Improve think tank and the newly launched manifesto go exactly in this direction. And as such, this is the time to take this message forward and propose concrete solutions and actions. The manifesto is the first essential step, and I look forward to upcoming actions and initiatives that can contribute to inspiring good solutions to the challenge of low blood pressure during surgery. Thank you very much.
Thank you. And if we could just have the slide up with the emails to connect. So if anybody wants to more information on this, please email improve@havasso.com. If you want to have a look at the report, have a look at the Improved Think Tank website shown here, the address here, and there's also going to be a copy of this webinar if you want to invite colleagues to have a look at that. But I'd like to say a huge thank you to our panel for presenting so clearly today and to our audience for taking part. Thank you so much.